Hello, my name is Hillengass. I'm the Chief of Myeloma at Roswell Park Comprehensive Cancer Center in Buffalo, New York. And we'd like to talk about our abstract at the this year's ASH meeting 2023 about the update of CARTITUDE-2 study, phase 2 study with cilta-cel to treat patients in early lines of therapy. Particularly cohort A was 1 to 3 prior lines of therapy with patients who are refractory to lenalidomide, and cohort B were patients with 1 prior line of therapy and early relapse after autologous stem cell transplant within 12 months. And I think this study is very important. It's an update. There have been presentations about this, but it's an update of longer follow-up because that's especially interesting in this scenario because we don't have a lot of data on early CAR T-cell therapy in multiple myeloma. So I think it's a very interesting data showing that these really excellent data that has been presented is really maintained over time. Not many more toxicities either, and not many more relapses in patients. So the patients have a really good outcome. And obviously we have to see with recent developments if long-term side effects are a problem in the early treatment with CAR T-cell therapy. But as you know, multiple myeloma is still an incurable disease. So treating early in patients who are not where the disease is not very mutated, not very evolved yet, might be a very good approach. And I think the CARTITUDE-4 data, which has also been recently presented, is definitely a confirmation of that, which is based on this prior study, which obviously has many more patients. And I think it's very important to see this longer follow-up for the CARTITUDE-2 study, and especially this early line or earlier line cohorts. Where I see a really urgent unmet need is especially the cohort B with the early relapse post-autologous stem cell transplant, which is even if the patients don't have a lot of high-risk features in their disease or at first diagnosis, they still show biologically that they have a very high-risk disease, at least when it comes to treatment, maintain treatment response and remission of the disease. The importance of this study, I think, is just showing that we can use CAR T-cells earlier, and there's a lot of rumor that we will have CAR Ts earlier in earlier lines of therapy soon. And there are other studies, obviously, with other products and also with cilta-cel, using it in earlier lines of therapy. And what we have to see is what induction treatment do we need? I think those are open questions. Do we need a maintenance, which is common after autologous stem cell transplant? So the question remains, after CAR T, do we really need a maintenance, or are patients already in a deep remission? We've seen very high MRD negativity rates, minimal residual disease negativity rates in this trial. So the question would be, do we do a maintenance treatment? How long would we do a maintenance treatment? And there's several multi-center trials going on investigating this, both the CAR Ts in earlier lines, but also maintenance, induction before. So another question might be, which are the best patients for these approaches? Can it be older patients as well? And there are studies going on with that in the whole setting. So I think it's still a very wide field that we have to examine, but having this data for CARTITUDE-2, CARTITUDE-4 is very important and kind of encouraging that we can try to be earlier in our treatment with more aggressive approaches. So I think that's where this study really fits very well in the treatment landscape nowadays. Yeah, I think there are so many things at ASH. It's an overwhelming program, obviously, but I think still CAR T-cell therapies are still really hot topic, and different settings, different combinations, then also the comparison with bispecific antibodies. Where do they fit in the picture? Should we use those first or the CAR T-cells first? At the moment, the tendency, I think, is rather to do CAR T first because of T-cell exhaustion. And that's another topic that I'm very interested in, what the immune system looks like in myeloma patients. There have been a lot of presentations and really amazing papers already on T-cell exhaustion, on other immune cells that are not functioning as they would in a healthy control. And I think those are topics where we have to learn much more to be much more effective in our treatments, especially in the realm of cellular therapies, of immunotherapies, and also development of new drugs. Even though we have these amazing treatments now, still myeloma patients die from their disease, and I think we have to learn more on how to prevent this and having even more drugs. I know we are spoiled with choice already, but we need even more drugs because patients still relapse. And since we use now quadruplet treatments upfront, oftentimes, at least in the US, we run out of options at one point. It might be many, many years later than it has been in the past, but we are still, as long as we don't cure myeloma, I think we still have the need to develop new treatments and new treatment approaches.